I think I'm old.
All right, so this will be immunology. This is going to be, it's going to make up about 50% of your exam. Just heads up. This stuff here is something that we're going to constantly be going back to throughout the quarter as well. Okay, so you're going to see a lot of recurring themes that we introduce here that show up. Yeah. Okay. So as always, you guys got questions, just shout them out. Okay. So immune system wise, this is going to be like more of an overview for the entire lecture. Okay. First line of defense, second and third. Second and third line of defense, this is the meat and potatoes. This is going to be 98% of your lecture. There's one slide on the first line of defense. That's it. So don't put emphasis on the first line. Second and third is where we're going to be really focusing. Okay, so your first line of defense is just defined by anything basically physical or chemical. It's on the outside. Okay, anything on the outside. Your second line of defense, there's 3 names for your second line of defense. Sorry, and yes, you do kind of need to know them. Okay, so your second line of defense is known as your innate immunity. It is also known as your non-specific immunity. And this is known as your inflammatory response. Okay, so 3 names: innate, non-specific immunity, and the inflammatory response. We're going to go through those 3 names, what they mean. This is just an overview. Second part of today's lecture will be the third line of defense. This one has 2 names associated with it. It's the adaptive or the acquired immunity. Sometimes you'll hear it as the specific immunity. I don't really use that term all that often, just because adaptive and acquired kind of cover that. Okay. So that's where we're headed today. In the cancer video, did I mention crash course?
Yeah.
Okay. Do you guys get a chance to watch that? Super fast, but hopefully those animations kind of helped. All right, so here's your one slide about the first line of defense. Okay, physical barriers include your skin, GI, GU, and your respiratory tract. So think about physical barriers just on the outside. It's anything that's exposed to the environment. Sorry. Anything exposed to the environment. Okay, so your skin, obviously, your GI tract from mouth to butthole, that's all exposed to in the environment. Okay, respiratory tract. Yes, I'm using very technical terms. I'm not a nurse. I'm going to soak it up all I can. Right? This is how you kind of maintain these physical barriers. I don't really care. I just need you to know where would you find physical barriers. Okay. Now, augmenting or helping the physical barrier is your chemical barriers. So things that come out of your physical barriers: saliva, tears, earwax, sweat, mucus. Okay, that kind of helps. We'll talk how there's antimicrobial peptides in there. Bacterial flora. So this is going to be native bacteria to you. Okay. Anybody familiar with MRSA?
Yes.
MRSA? What is MRSA? What do you guys know about it? It's antibiotic resistant. It's real nasty. What else? It can get in your nose. It's a flesh-eating bacteria that is antibiotic resistant. Anybody been to the hospital recently?
Yeah.
It is everywhere. Chances are, sorry, Rebecca, you got MRSA. Chances are you got MRSA on your skin right now. You guys as nurses, you're gonna have MRSA on your skin too. Now, why don't you guys have flesh-eating bacteria like ripping holes in your skin right now?
Carriers, your normal flora helps protect you.
Your normal flora, right? So what your flora does is this creates a competitive market. Because you have other bacteria on your skin, that other bacteria is fighting with MRSA. They're too busy fighting one another rather than infecting you. Okay? So that actually helps you out. And that is it for the first line of defense. All right, now we're jumping into the second line of defense, or the innate immunity. All right, so 3 names for this. Innate immunity. So when something is innate, what does that mean? Was it you? Oh, sorry, I saw Tim walking by. I thought he was like, forward. Sorry, that was good.
I should have said no.
Innate immunity. If someone is innately a certain way, they are born with. Okay, so what this means is you are actually born with this immune system. You were born with the second line of defense. Another name for it is non-specific immunity. It is non-specific because it treats everything the same way. Okay, it doesn't matter if it's bacteria, doesn't matter if it's a parasite, doesn't matter if it's an amoeba, doesn't matter if it's a cat. Okay, doesn't matter. It treats everything the same way. Treats everything the same way. Okay. And the last one is called the inflammatory response, because it deals with histamine release. Okay, so 3 names for your second line of defense: the innate immunity, non-specific immunity, inflammatory response. Heads up, I can refer to the second line of defense with any 3 of those. Okay. Now, one of the things incorporated into your innate immunity are all of these cells. We're going to kind of run through them and kind of organize them a little bit. So first up, mast cells. Mast cells, these are going to be just cellular bags of histamine. Okay, bags of histamine. Think of it like a water balloon. These are stationary. The analogy for a mast cell is kind of like your fire alarm. Okay, if I were to run out into the hall and pull the fire alarm, that would designate that the basement is on fire. Yes, not the first floor, not the 1.5 floor, not the 2nd floor, just down here. Agreed? So we have mast cells all over our body. If I cut my left index finger, it's the mast cells at my left index finger that release histamine, not my eyeball. Okay, so does that make mast cells a blood cell or not?
Yes. Oh, no.
Because they're stationary, mast cells are not blood cells. Not blood cells. So we don't include mast cells in, take for example, white blood cells. Okay, mast cells are stationary, they're not considered blood cells. Leukocytes, leukeo translates to white. These are just your white blood cells. There are several different types of white blood cells that we're going to get into. Okay, granulocytes, granule. It's like a granule, a grain of sand. Granulocytes contain grains of histamine. Okay, so if a granulocyte is a type of white blood cell, what's the main difference between a granulocyte and a mast cell? Granulocytes are blood cells, therefore these ones are moving. Your mast cells are stationary, okay? Monocytes, macrophages, we're going to talk about. Lymphocytes, this is going to be the third part of lecture. These are your B and T cells. Okay. Again, that'll be in the third line of defense. Other phagocytes, we'll talk about them. Platelets, keep it simple. What do platelets do? Clotting, stop bleeding, however you want to say it. Okay. So this is just an overview of the cells. We're going to get more in depth with it. Okay, so your granulocytes. Keep it simple. Granulocytes. These are cells that contain grains of histamine. Now we talked about when we release histamine, what kind of response does that lead to? Inflammatory. So if these granulocytes release histamine, what are they doing with inflammation? Are they ending it? Are they starting it? Are they continuing it? It's not starting it. Continuing it. So your mast cells are the fire alarm. You see, this is kind of tricky here. Your mast cells are the fire alarm. You pull the fire alarm, that alerts the fire department. The fire department's mobile, the alarm isn't. So your granulocytes continue, prolong, or enhance, i.e. make it worse. Inflammation. So how you can remember your granulocytes is an acronym, BEN. Basophils, eosinophils, neutrophils. Okay. So BEN, basophils, eosinophils, neutrophils, all of these are granulocytes. That means all three of these do what? Release histamine, which will continue, prolong, or enhance inflammation. That's how you can kind of read into this. All three of them share that common characteristic. Now, there are some unique characteristics to these individual cells. Anybody know what makes basophils unique? Close. That's almost. Next one. It's the answer you're giving me right now. That's a legitimate answer. We actually don't know what basophils do. We actually don't know what they do other than release histamine. Eosinophils, though, they are actually pretty unique. Okay, these are the only cells that can fight parasites. Okay, these are the only cells that can fight parasites. So why is it that we can still get tapeworms? Why can we still get ringworm, for example? You don't need to know. You don't need to write this down. Out of all of your blood cells, eosinophils are the least. You have the fewest amount of eosinophils, so that's why the parasites usually win. Okay, but you don't need to write that down. The other key thing that they do is they will regulate. So, i.e., they will control. They can turn up or they can turn down. They regulate histamine release. Okay. So kind of think of your eosinophils like the fire marshal. Either they're going to show up on scene and they're going to say, "Hey guys, turn it up or turn it down. We need more histamine or we need less histamine." Why would we want less histamine? Yeah, maybe my wound isn't so bad. Maybe I don't need to be super inflamed. Okay. Why would I want to turn up histamine? Yeah, maybe instead of getting cut with, like, I don't know, a scalpel, I got cut with a rusty spoon. Maybe the infection's pretty bad. We need more inflammation because there's more pathogens in them. Okay, so your eosinophils, They're the ones that control histamine release. Therefore, what response do they control? They control the inflammatory response. So who's responsible for telling you to stop being inflamed? Eosinophils. Okay, they're the ones that tell you, all right, we're done, we're good, the infection is clear. Okay. Neutrophils. I'm going to kind of leave this a little ambiguous here. Neutrophils, I know we kind of said this before, but I'm just going to say release histamine. Okay. All three of them release histamine. I'm just mentioning that your neutrophils can release histamine. Okay. So those are your granulocytes, i.e. Ben. Next up are your phagocytes. You probably heard of phagocytes before. Phago, does anybody know what phago translates to? Eat. These are cells that eat. Cells that eat. I'm going to say foreign pathogens. Okay, so these cells can eat. Now, when you meet a person that can eat a lot, we're talking about, I don't know, you take them to Golden Corral and they just clean out the entire rib cage. What do you say? Damn! That's how you remember that. These cells can eat, and boy, can they eat. I don't know. This is the way I remember it. You can think of like mind, whatever works for you guys. So D is going to be dendritic. M is macrophage. N is going to be neutrophil. So your dendritic cells, these are almost like a Venus flytrap. Okay, what they do is they basically anchor to, I'm going to say, a vessel. And they have these really long arms. They're going to reach out with long arms. And what they do is they grab a pathogen and they rip its face off. Now, I'm being particularly gruesome here because this ties into the second part of the lecture. It will physically tear the face off of bacteria or parasite. And what do you think it does with that face? It wears it. This is like Leatherface right here from Texas Chainsaw Massacre. Okay, so it will, and you can quote me on this, rip off face and wear it. It's kind of odd. Macrophages, you guys probably know these ones right here. I'm going to just flash back really quick, and I promise to come back to it. All right, you guys see monocytes versus macrophages? Monocytes are just baby macrophages, okay? Think about what's easier to transport, a small cell or a big cell. So what we do is we release these small baby cells into the blood. When they get to the site of an injury, that's when they turn into a macrophage. I don't really ever use the term monocyte. I just kind of refer to them as macrophages. So just heads up about that. Okay, so a macrophage, these are the ones most people are familiar with, yeah? They eat stuff. Now, what's kind of interesting about a macrophage is when it eats a pathogen, particularly like bacteria, it throws the lysosomes at it to break it down. It dissolves this thing in acid. What do you think it does with the leftover body parts? It's already eaten it. It vomits it back out. What do you think it does with all these leftover body parts?
Where?
Your macrophage will eat stuff, vomit out, quote unquote body parts to wear as jewelry. So yeah, your macrophages are running around with like the bones of sorts of the bacteria it's meant. Your immune system is really brutal, y'all.
So just to be clear for me, so the dendritic cells, they rip off the face and wear it, right? And then give the body parts the macrophage.
Oh, they can work in tandem, but they usually don't. The dendritic cell is just gonna shred it apart and then wear those parts as jewelry. Macrophage, when it needs something, it's just gonna eat it and then wear it.
Oh,
So
okay.
they work independent of one another. Okay, neutrophils. We've talked about neutrophils already. What do neutrophils do? They release histamine. But here we're saying that they're also a phagocyte. So that means they also eat stuff. So what I'm getting at here is do not take these as three different categories of cells. There's overlap. There's overlap. Some cells can be both a phagocyte and a granulocyte. Okay. Now the weird thing about neutrophils, when they eat stuff, they operate on the one and done principle. As soon as they take a bite out of crime, they explode. They instantly self-destruct. In fact, you've actually seen dead neutrophils before. What comes out of a really particularly nasty wound after a few days? Those are dead neutrophils. So we'll talk about that a little bit, just foreshadowing. Okay, so they can only eat one thing and then they self-destruct. The third category is diapedetic. Ped means foot or to travel. Diapedetic, these are cells that can squeeze in/out of blood vessels. Cells that can squeeze in and out of a blood vessel. So this is kind of beneficial. If I cut my finger and there's a bunch of pathogens in my finger, I need cells to be able to leave the blood vessel to attack whatever's in my finger, yeah? So what is the most slipperiest of creatures that can get out of anything? Men. You give us an excuse and we're out of there. Sorry, Greg, I'm just speaking for myself, bro. Again, this is how I remember them when I was an undergraduate, so hopefully this helps. So what kind of cells can squeeze in and out of blood vessels? Macrophages. E, we've actually come across a cell that starts with E. Eosinophils can squeeze in and out of blood vessels. N. So again, you guys see how what I mean by this? There's overlap between these different categories here. Okay. What else does an eosinophil do? It releases histamine, controls histamine release, fights parasites. So neutrophils. Why are neutrophils the jack of all trades? What can they do? What are the three properties that neutrophils have that we've talked about? They can release histamine. They can eat stuff. And finally, the third one here, they are diapedetic. So your neutrophils can do it all. They can do it all. Why don't we just rely on neutrophils? Why do we need other cells? Because they're one and done. They're too short-lived. Okay. So these are the cells that we're going to be talking about with the innate immunity. I'll probably show this link break. It's actually kind of cool. So still talking about the second line of defense. We haven't moved anywhere yet. Known as the inflammatory or the innate response. What's the third name? Non-specific. Okay. When it comes to the inflammatory, the innate response, or the non-specific response, it's comprised of two parts: a cellular component and a protein component. What we just talked about with Ben, Man, Dan, that was a cellular part. We will talk about the protein mechanisms a little bit here later, okay? For local manifestations of inflammation, heads up, I use manifestations, signs, and symptoms interchangeably. Lindsay's gonna be a little bit more particular about which one is which. I don't care, I just call everything a symptom. Just heads up. I will not test you between the different types. So local manifestations, local symptoms, local signs include swelling, heat, a possible loss of function, redness, and pain. For those eagle-eyed viewers, what does that spell?
Sure.
That's how you remember that. SHARP is an acronym for your local signs and symptoms of inflammation. Okay. Why I say a possible loss of function? If I get a paper cut, do I lose my finger? You guys see what I'm saying? Like, grain of salt here. Now, you might ask why. Why do we see these symptoms here? Okay, this slide here kind of introduces something that we'll be talking about a lot. Whenever we talk about inflammation, there are two bodily effects. Know these well. They're going to be all throughout the entire quarter. Two effects of inflammation. One, blood vessel dilation. Two, increased vascular or capillary permeability. What does permeability mean? Yeah, the ability to go in and out. If something is permeable, things can pass right through it. Okay, so when we release histamine, that triggers inflammation. That causes these two things. Why, if I cut my finger, why do I want my blood vessels to vasodilate?
To get more cells there.
More cells, more fluid, more blood. So I'm going to say blood vessel dilation for increased perfusion. And we're good with the term perfusion, yeah? Okay. Why would I want to increase vascular permeability? Why do I want to increase more things leaking out of my blood vessels? Leaking out prevents things from getting in, absolutely. Which immune cells can squeeze out of a blood vessel? Macrophages. What else? Neutrophils and eosinophils. So I'm going to say allow cells to diapedese. I don't think I spelled that right. Okay, just allow cells to leave the blood vessel. That's what I'm trying to get at, men. Okay. If more things are leaking out of the blood vessel, does that explain swelling? Why are we swelling? What else is leaking out of my blood vessel? Fluid. Fluid. What about heat? Why would my cut feel hot? You warm-blooded or cold-blooded? If you get more blood to the site, it's going to get hot. Loss of function and redness. Why would my cut be red? More red blood cells. You guys see what I'm saying here is I'm going through this and I'm asking why? Okay. Why would I feel pain? Haven't gotten there yet, but we will. Okay. So here's just a nice visual representation of what we were talking about. Inflammation has two effects. What were the two effects of inflammation? Vasodilation.
Increase
And increased permeability. Here's a capillary bed. Here's a capillary bed on inflammation. Notice your blood vessels have vasodilated, and you have more cells outside of your capillary bed. Okay, so again, two effects. Know them well. Okay. Why do we get inflamed? What's the whole point here? The whole idea here is to recruit immune cells, provide a barrier, and prevent/limit infection. We will not be talking about wound healing just because there's not enough time, unfortunately. So whole purpose of inflammation, bring on the immune cells, stop the infection. Okay. Now, can your second line of defense tell the difference between staph versus? The answer is no. I can't give it right now. Why doesn't your second line of defense discern between different types of bacteria? It's non-specific. Okay, so even if it's a virus, same thing. We would see the release of histamine. We would see vasodilation. We would see increased capillary permeability. Same thing with a parasite. Okay. All right. So thankfully, we've already gone over it. So this kind of makes things a little bit faster. So your mast cells, again, the analogy here was that it was your local fire alarm. Okay. You have these throughout your entire body. They are just bags of histamine. And as soon as you pop a water balloon, water goes everywhere. As soon as you pop a mast cell, histamine goes out everywhere. So your mast cells release histamine. Again, these are stationary, not considered blood cells. They also release chemotaxic factors. Chemotaxic factors, these are chemical attractants. Chemotaxic factors are just chemical attractants. So I cut my finger, that ruptures the mast cells, they dump histamine. What kind of cells do I want to attract to my finger? Macrophages, who else? Neutrophils. Do I want to be inflamed forever? So eosinophils. So I'm just hinting at that. We're going to get to it. We're going to attract our white blood cells to the area. Okay. Now we've got a water balloon. We rupture it. All that water's gone. Inflammation. Does it work that way? You get a cut, it's red, and then it deflates. So first step is we degranulate. We dump everything out. So step one, degranulate. Once you dump out all your histamine, guess what? You got to make more histamine. So mast cells, you injure them, they degranulate histamine. They're all out of histamine. Now they have to synthesize histamine. 2 steps. Okay. And there's a picture coming up for this. Oh, hey, look at that. It's bolded and underlined. Weird. Okay. Now, if you notice before, chemotaxic factors was spelled with an X above. Here's CT. It just depends on what kind of English you speak, depending on which side of the pond. I spell it with an X. I spell taxic with an X. So if I ask you a question about chemotaxic factors, expect an X. If you want to spell it with a CT, that's fine as well. Either one's fine. Again, these are your chemical attractants. The 2 main cells that we want to attract. neutrophil chemotaxic factor and eosinophil chemotaxic factor. Okay, those are the two main cells you want to attract. So neutrophil chemotaxic factor attracts neutrophils. Don't overthink it. Okay, so why neutrophils and not macrophages? Neutrophils, they're small, they can do everything, easy to transport, easy to make. Macrophages, that's kind of like the National Guard. Takes a little while before they can mobilize. Yeah. So here is a nice little picture. Let me say, you do not need to memorize this. You do not need to memorize this. This does come up in farm. You don't even need to know the name if you don't want to. This is the arachidonic pathway. Again, you do not need to memorize this. There's only a few byproducts you need to be concerned with, okay? So here's your mast cell. Notice it's a bag of histamine. As soon as it gets damaged, what process does that start? Starts with degranulation. So step one is over on the left there. What do we degranulate? We degranulate histamine and chemotaxic factors. Now, after we've dumped all of our histamine, what do we have to do now? Synthesize. The things that we are going to be synthesizing, things you need to worry about, platelet activating factor and prostaglandins. Okay. So if a mast cell degranulates, what response is that triggering? So degranulation is the trigger to start inflammation. Why would a mast cell want to synthesize additional histamine? To continue or prolong or extend, I'm just gonna say to continue inflammation. Who's gonna tell the mast cell to stop synthesizing histamine? The eosinophils, your shutoff valve there. Okay. So that's how you can kind of take a look at this picture. Left side is for starting, right side is for continuing. Okay. So mast cell synthesis mediators, this is on the right side here. We're talking about things that they synthesize. The only two you need to worry about is prostaglandins and thromboxanes. Okay. Again, what's the whole point of mast cell synthesis? To continue. That's why prostaglandin is similar to histamine. It works like histamine. You still have vasodilation, you still have increased permeability. New thing here, that causes pain. If I cut my finger, why do I want pain at my finger? Yeah, to let me know that there's an injury, that something has happened. So remember sharp? That explains your pain. Okay. So what cell causes pain during inflammation? Prostaglandin is the chemical that comes from mast cells. Okay. Now thromboxanes, thrombo, anytime you see thrombo, those deal with your thrombocytes, i.e. your platelets. So what's the whole job of thromboxanes? Clotting. Yeah, easy enough. Okay, you do not need to worry about leukotrienes or prostacyclins. Only two I'm worried about is prostaglandins and thromboxanes. That's way too hard. Yeti does a really good job. All right, phagocytosis. So we're talking about things, cells that eat stuff. Two ways for this to work. It can either pavement or undergo diaphodesis. Okay. Pavementing is when the white blood cell sticks to the wall and eats things as they go by. What cell does that remind you of? The dendritic cells. Remember, these are your venous flytrap. They travel through the bloodstream. stick to the blood vessel and they grab things as they go by. Now, what cells, actually, let's start with this. Diapedesis. What is your acronym for cells that are diapedetic? That's men. So macrophages, eosinophils, neutrophils are diapedetic. Which ones are phagocytes? Macrophages are diapedetic phagocytes. Eosinophils. They're only diapedetic. Eosinophils are not phagocytic, so that's why I'm putting a line through that. Okay, eosinophils, yes, they are diapedetic, but they are not phagocytes. Neutrophils, are they diapedetic?
Yes.
Are they phagocytic?
Yes.
Yes, so the only two cells that are both diapedetic and phagocytic, macrophages, neutrophils. Okay. And a little bit more reading, but again, this is going to go pretty quickly. Neutrophils, they are your primary cell in the inflammatory response. These are like your first responders. Usually they get there within, it says, I would say they're going to get there usually within an hour. Okay, which makes sense. You cut your finger, do you want neutrophils there sooner? Yes. Okay, they usually arrive on the scene or at the injury within an hour. They eat stuff. That's awesome. What's the problem though if they eat stuff? One and done. Okay. Now we kind of mentioned when a neutrophil takes a bite out of something, they explode. Their dead bodies kind of pile up and they make. Now, as a nurse, you don't call it pus. You guys call it purulent exudate. Okay. So what?
I can't say purulent.
Purulent exudate. But you can say pus. But heads up, as a nurse, if a wound is full of pus, actually, let me just write the pus in here. How would you describe that? Don't describe it as blank E. You get what I'm saying here. You never describe a wound as E.
Oh, I get what you're saying. I made that mistake once.
So you would say significant drainage or purulent exudate. So that's why I say, like, as a nurse, you might want to stay away from the term pus, but it's a layman's term. Most people knows what it is. You know, just be careful of that landmark. Monocytes, macrophages. We talked about. These are the calorie. It takes about 24 hours. It takes about 24 hours for them to show up. But when they show up, they can keep eating and eating and eating. Okay. Dendritic cells, again, was that kind of Venus flytrap, or yeah, Venus flytrap. It's known for ripping off faces. So this here is just a picture of how your phagocytes decide what to eat. Once they identify something that they can eat, they bring it in. Again, this is more your macrophages. And then they start dissolving it. They start dissolving it. So therefore, what organelle is necessary for a phagocyte to do its job? The lysosomes. Because your lysosomes are filled with acid. That's how we break it down. You see all these little pieces? That's what gets vomited back out, and that's what gets worn as jewelry. All right, so that was the cellular response to inflammation. Now we're going to be talking about the chemical response, or the proteins, your plasma proteins. Anytime you see plasma in the healthcare field, what kind of fluid is that referring to? Blood. So these are proteins just floating around in your blood. Okay, now proteins, are they sentient? No, they're just proteins. They're just like little chunks of chains of amino acids floating around. Okay, your body just naturally makes these proteins. You are circulating these plasma proteins right now. Okay. Now, these plasma proteins, I want to emphasize, are not antibodies. We'll talk about antibodies in the second part. These are not antibodies. These proteins are floating around and they complete one of three functions. Okay. So just an overview, the complement system is like a tagging system. Complement system is like a tagging system. So that means when something is foreign and it's floating around in your blood, these plasma proteins just stick to it. So if you see a cell in your blood covered in plasma proteins, what does that tell you? Yeah, they're not from around here. That's not yours. Get it. You see how this is a tagging system? This helps the macrophages look for things that are not you. Okay. Coagulation, kind of already talked about it. It's just clotting. Cool. Kinin, your kinin system. This is responsible for pain. So what I'm hinting at is this is the second source of pain with the inflammatory response. Okay. So first up is that complement system. Again, this is your tagging system. What do you want to tag? Sticks to foreign pathogens. So imagine covering, like back in grade school, do you guys ever try to hang up your friends with duct tape to the wall? Okay, sorry, I'm weird. If you start duct taping somebody to a wall, it's kind of funny, right? What happens if you keep using more and more duct tape? What happens if you accidentally, like don't do this on purpose? What happens if you duct tape over their face? Sometimes these plasma proteins can cover a pathogen so much that pathogen can't breathe. Sometimes. Other ways, some dude's walking down the street with a lot of duct tape. It just tags them. Okay. Now, your coagulation / clotting, we will talk about this more so in exam 4. All we need to know about it is it helps you stop bleeding. Good. That's all you need to worry about. We'll talk about it more in depth later. The last plasma protein system is the kinin system. Kinin is a type of protein. The specific kinin we're going to be looking at is bradykinin, because bradykinin causes pain. This is a substance that can actually directly trigger your nerves. We'll talk more about triggering your nerves with exam 2. What I need you to know is kinin, particularly bradykinin, causes pain. That's what you need to know for exam 1. What else causes pain? Prostaglandins from your mast cells. So mast cells can cause pain and your plasma protein systems can cause pain. Okay. All right. So cytokines, cyto just translates to cell. Kines is signal. So these are signals sent between cells. Okay. The only cytokine that I will test you on is interferon. The only cytokine you need to worry about is interferon. Now, how interferon works is it protects against viral infections. Okay, so imagine that we are all cells in some tissue right now. Okay, how a virus works is it invades a cell and takes over from the inside. So take, for example, all of us, we're just chilling here. If I was to tell you that I have the flu right now, Would that be helpful to know? What would you do with that information if I told you that I was sick? You wear a mask, you scoot back. You see what I'm saying? That's how interferon works. As soon as the cell's infected with a virus, it's a signal to say, hey guys, I'm sick. I have a virus inside of me. Be ready. Okay. What kind of signal is that if I'm communicating between me to you? Paracrine. This is a paracrine signal. Does anybody in the hall know that I have the flu? Uh-huh. I don't. So interferon only works between neighboring cells. So again, a virus, how it works is the virus, this blue one here, invades the cell, it hijacks the cell, it steals everything, resources, the systems, and it replicates in here. After everything's been used up, that cell explodes, sending copies of this virus elsewhere to invade other cells. This cell here knows that it's gonna die. This cell knows it's infected with the virus, it's gonna die, so it releases interferon. The neighboring cells, they get that interferon, like, oh, okay, a virus is in play, let's get ready. So when this cell dies and releases that virus, we are ready to directly attack that virus. Okay, so interferon, what I'm getting at is a paracrine signal for fighting viruses. All right. Take a breath. We're going to take a step back from the cellular stuff. We're going to go more, which you can observe as a nurse. Acute inflammation is self-limiting. When something is self-limiting, it's basically caused by one thing. Okay, so when something is self-limiting, I cut my finger, there's pathogens in my finger, it becomes inflamed. Once I kill all of the pathogens, what should happen to inflammation? Should decrease. That's what self-limiting means. Okay. Whenever you figure out the cause and you treat the cause, the symptom should go away. Local manifestations we've already talked about. What are your local manifestations? What are your local symptoms of inflammation?
Swelling.
Swelling. Sharp. Loss of function. Okay. And along with sharp, certain things, certain fluids come out of the wound. What kind of fluids could leave a wound? Glad you asked. Joking. Serous exudate. Serous exudate is very watery. Anybody have any tattoos?
Yeah.
When you first get a tattoo, or when you first get a cut, we're talking about within the first maybe hour, it's kind of shiny. That's serous exudate. That's basically water coming out because it's primarily blood plasma. The main ingredient, the main component of blood plasma is water. That's why it's shiny.
Is accident kind of an like discharge?
Yeah. You can say serous discharge. Typically, when you're talking about fluids coming out, you say exudate, but yeah, that's fine. I'll always refer to it as exudate. I won't say discharge, just because. For some reason, I think discharge is like it comes out with some velocity. So I'm just saying it's leaking out. Fibrous exudate, we're going to come back to. Purulent exudate is, i.e., also known as pus. What is purulent exudate? Dead neutrophils or successful neutrophils, half empty, full cup kind of person. Hemorrhagic. Hemo refers to what? Blood. So what's coming out? Blood. Cool. So, now getting to fibrous exudate. So fibrous exudate is very thick. It is, for lack of better terms, chunky because of scar tissue. It has collagen in it. Okay, so usually, like, what I'm getting at is fibrous exudate is probably the most advanced sign of inflammation. That means this person has been inflamed for weeks. Anybody ever work with any chronic smokers? When they start coughing and they cough up that loogie, it's chunky. That's fibrous. Remember, it takes weeks for scar tissue to show up. Okay, so one exercise I might say is patient receives a wound. Which exudate would a nurse expect first? I would say, yeah, serous or hemorrhagic. Sorry, trick question. Just depends on how deep it is. Right? If I get cut, you should see watery stuff or full on blood. What should a nurse see next within maybe a few days? Purulent, yep. And finally, fibrous. Okay. Now, this can have a little bit of a spin. Again, let's use myself as an example. I step on a rusty nail. 3 days later, we see purulent exudate at the wound. Physiological or pathological? It's physiological. 3 days later, we would expect to see purulent exudate at the wound because that's a rusty nail. It's not a surgically autoclaved nail. Okay, it's a dirty nail. We would expect infection. We would see purulent exudate. Now, same, stepped on the nail, but now I see purulent exudate 4 months later. Pathological. Why am I not healing? Does that kind of make sense? So, exudative fluids kind of suck for the patient, but it's kind of helpful for you because if you see fibrous exudate, what does that tell you about that wound? It's been there for a while. Maybe they're not cleaning it. Maybe it's new infection. Something's going on. Okay. All right. Fever. So now we crossed the line. We went from local, sharp, to systemic. One of the systemic manifestations is a fever. If I step on a nail, I got pus on my wound. 4 days later, I develop a fever. What does that tell you about my infection? It's spreading. Yeah. It's pretty bad. It's getting worse. When you see a fever, that means the infection made a jump. The infection went from local to systemic. We'll talk about the brain a little bit, but for now, your hypothalamus, that's the part of the brain that controls your body's temperature. That's your internal thermostat. Leukocytosis means increasing white blood cell production. You're making more white blood cells. Why would I want to make more white blood cells with a systemic infection? To fight it off better. So I get a nasty infection. What would be the physiologic response in terms of white blood cell count? Should white blood cell count go up or down? Should go up. That's the natural response to a systemic infection. Patient is in the hospital, stepped on a nail 7 days ago, no change in white blood cell count. That's pathological. That's weird. Why is this person not making more white blood cells despite having a fever? Okay, is that hopefully eliminating physio versus patho? Okay. All right, chronic inflammation. So depending on who you work with, your specialty, and which textbook, we have a different timeline. For me, this class, my quizzes, my exams, if you have been inflamed for more than 2 weeks, we have gone from acute inflammation to chronic. Okay. So chronic inflammation is 2 weeks or longer. Just heads up, in the real world, things can be different. Okay. And I don't care about that second one. If somebody is chronically inflamed, What does that tell you about the second line of defense? Maybe it's not enough. Most wounds should be cleared up in about 2 weeks. Inflammation should be gone. If the wound isn't clearing up, well, you know that your second line of defense probably isn't doing enough. Probably can't kill it. Dysfunctional wound healing. All right, so we're gonna do a really quick recap here. What I would recommend is get a spare sheet of paper for this. There's not gonna be enough room on those little slides there. Does anybody need a spare sheet? I got some. All right, so just recapping what we talked about. First line of defense. What made up the first line of defense? Physical and chemical barriers. So anything exposed to the environment, yeah. Now we get into the second line of defense. What were the names for the second line of defense? Innate, non-specific, and the inflammatory response. Okay. Innate, non-specific, and inflammatory response. Now, if something has, the reason why I draw it this way, you don't actually draw this on yours, it's gonna make it too cluttered. The reason why I like to draw it this way, if something breaches that first line of defense and brings pathogens along with it, it's like a visual way to kind of like see what's happening. Who's going to alert us that something has broken the first line of defense? The local fire alarm, the mast cells. Now, mast cells operate 2 ways. What were the 2 steps to a mast cell's function? Degranulation and synthesis. Okay. What does a mast cell degranulate? What does a mast cell just dump immediately? Histamine is one. Yeah, my chemical attractants, those chemotaxic factors. Histamine was pretty important. How many effects of histamine were there? I secretly give you guys the answer via my hand. I'm not flashing it up again. How many effects did histamine were there? 2. They were vasodilation and increased, let's just say, permeability. Now I'm all out of histamine and chemotaxic factors. What do I synthesize? Prostaglandins. And something to help me clot. Thromboxanes, yeah. So that's why I did 2 different colors there. Blue is degranulation, purple is synthesis. All right, chemotaxic factors, what are they doing? Neutrophils and the shut off, the regulator. Eosinophils. So there's not really an easy way to draw this. So this is kind of like my shortcut. Your chemotaxic factor is just going to bring all of your cells, including granulocytes, phagocytes, and diabetic cells. What was the acronym for granulocytes? Ben. Phagocytes? Damn. Diabetic. Yeah. So eventually, all of these cells will show up. First are the neutrophils and the eosinophils. There's just not an easy way to draw that. Prostaglandins, why are those important? They cause pain. Thromboxanes, I'm just going to say clot. All of that because of your mast cells. Now, inflammation is two parts. One part cellular, which we just drew here. Second part is chemical. What was the chemical or protein component to inflammation? That's one of them. We have our plasma protein systems. 3 of them. First up was the complement. What else? Coagulation. And one more. Yeah, kinin. I'm just gonna write bradykinin here because that's what I refer to it as most of the time. Complement sticks to stuff, coagulation helps you stop bleeding, but bradykinin is important for Nazi. Oh no. That is the second line of defense. We are getting into the third line of defense. We're going to let's go for like a little over 10 minutes. So we'll say we're going to start at 10. Yeah. I'll leave this up here if anybody wants to copy it. So no rush. If you want a photo, you're more than welcome. I would say actually just chill out because we're going to do this again, but incorporate the third line of defense. Okay. Yep.
I don't know if you know the answer to it, but like, if somebody's having like a mast cell activation, like that immune response, are they like more at risk of clots because of
That could be part of it, absolutely. So you gotta think about which one we release first, right? So we've done histamine first, because I think you're thinking about like allergies. Someone has an allergic reaction to this from clot.
Well, because there's some people that like they have a mast cell activation disorder, and like so they can. I don't know if they respond to like some kind of allergen just randomly, and that's why it happens. But like, I don't know. It's not important to the test or anything.
Yeah, just curiosity. My guess is no. The reason is because with most, this is getting a guess, don't quote me on this. The reason I say no is because most mast cell tissues, they're just degranulating.
Okay.
They're not synthesizing. So the biggest issue with these mast cell sensitivities is that they're just dumping all of this histamine that's causing the capillary permeability and vasodilation. You shouldn't see clotting issues because the synthesis requires another signal.
Oh, okay. So like in the case of like reactions, it stops at like 8, right?
But let's do that you're reading. That's what I mean.
Because I've only gone to the once, but I remember like just full of pain, like all over my body. And so that's why I was wondering. Because the chemotoxic factors, that's still on that left side, right? No,
Yeah, chemotoxic factors are on the left side there.
but then is the prostaglandin helping?
Yeah, my guess might be bradykinin. It's also being activated to cause pain. This is just plasma. Another thing that can cause the pain is this sudden increase of blood flow, right? So think about fluid moving through a tube. More time to get fluid, pressure increases as it stretches too,
Okay,
getting with your tissues or muscles.
cause like my legs did get really swollen, but like I just felt like a lot of be ready to be around.
It's because when your vasodilating up to the top there, that's what gives you that sensation. It's just the pushing the surface and spring. It's weird. Yeah, and I thought like we'll talk about hypersensitivities tomorrow, but it's the things that are meant to protect us and save us can definitely get crazy and kill us. Madeline? Damn it, sorry. I'm trying to practice. Alexis? You're Alexis, okay. Give me the first letter. Nicole? Okay.
Yeah, okay. Are you coming from my post? Yes.
Because the president is very huge. It's fortunate, so
Very
like
cool.
my brother, my son.
Okay,
Great.
awesome, very cool, yeah, really awesome. So really big.
Yes, what's up for that 2020? So mean and accurate.
I would have been beside myself if that's, because that's like all I had. So I- it wouldn't have been. I do remember that stuff, and then, I don't know if you remember the Denver field hockey. But I do make plays for them, but I used to have coach at school up in Jersey, so it's just not as big out there. So hockey's like pretty well. Too, it's on the East Coast, so, but yeah, I do, I have to do Christmas maybe for a lot of my friends, so I have to go back in Jersey. So I still need to live my life, so I always will, like. Oh, yeah, be super, for sure. For sure. It's always like to develop a different relationship with it too. Like especially like a lot of that suffer from identity crisis when they don't have their story. Whether it's student income or just retirement, whether that's at a high school, college, professional level. It's, I mean, I've done a lot of studies. It's the best people who so heavily identify with something. Doesn't have to be a sport, it can have to be
It's like within my son.
really. That's why now I try to look everything down, it's like what it's like to blindly love something. It's a lot. But that's what it takes to be sure that's good. I just had to point it out. Yes, really like. I'm like, oh, that'd be nice. That's fair. Yeah, like hang out outside. Yes. Yeah.
Please.
So my second eosinophilic esophagus, eosinophilic esophagitis. Anyway, so they just did a biopsy on his esophagus again, and they discovered more EOE, but they also discovered neutrophils in his, they said that that's causing more acid reflux. So what line of defense is that? Is it in the second line of defense? That's the second line.
Yeah, because you got those neutrophils and you got those eosinophils.
And so then is it kind of dysplasia or is it a metamorphosis?
At first, it's going to be metaplasia.
Metaplasia.
I believe when that becomes Barrett's esophagus, I think is the next step beyond that. That Barrett's esophagus is dysplastic, is my understanding.
Okay.
My understanding, but like, take that with a huge grain of salt.
Yeah, no, because he was just saying, it's the whole branch out.
Yeah, I'm just wondering why the eosinophils would be called the esophagus. So odd.
It is the parasite. And so we've been struggling with it for the last year and a half down in Colorado Springs. So now we're getting sent up to Denver to an EOE clinic specialist that has 4 specialties, the GI, the allergist, swallow therapist, and a nutritionist.
I'm wondering if it's a mast cell thing. And what, like, do antihistamines help?
I don't know, they wanted to put him on a steroid,
Uh-huh.
but that will affect his bone growth, and he's such a huge, ice hockey, football, baseball, very competitively. And he's a bit so, I don't want his bone.
Yeah.
Has
And then we can also throw off metabolism and things like
yeah,
that too.
so we are trying to do it through nutrition.
Yeah, and I would ask, would an antihistamine help? So basically, if mast cells are attracting your eosinophils to the esophagus, let's just get the mast cells to calm down. That's generally what they're doing with the steroids, but you can also do the same thing with Benadryl.
So that's his first thing, because then I think he has allergies to other things. Okay.
I know.
But anyway,
Yes.
so Benadryl is, so we're staying on it, his neck is itching.
Yeah.
So, but okay.
I would say like, just ask. Like,
Because he had 181 eosinophils in his last biopsy in his esophagus in one spot, and then 120 in the others, and it's jumped. But the only thing that we changed was he added a lot of soy. So we think soy is causing.
Interesting.
We have to take away all meat. Dude, it's hard.
Kid, oh, poor kid.
So then all meat and stuff has soy in it.
Uh-huh. Huh. See, I know soy can promote inflammation, but only in very certain circumstances. I don't know. I've drinking nothing but soy for most of my life. I'm doing okay.
Yeah. And it's not everyone, it's not every, it's gonna be more and more well known this year.
Yeah.
Like, what the hell is that?
Yeah.
But
Yeah, that's odd.
it is very odd. But it's the second line of defense.
Mhm.
Yeah.
My guess is like the mast cell, the reason why it's my guess is the eosinophils are swarming in that area. It's because the mast cells are releasing those chemotoxic factors, telling your eosinophils to show up.
This is our assumption.
That's just a guess though.
He has his first appointment, I knew it was number 21st.
Gotcha. Of course.
Don't really.
All right, guys, so we're gonna try to wrap this up here. This will be the third line of defense. Now we're gonna be talking about things that inflammation can't kill. So bringing up the third line of defense here, this is the adaptive or the specific immunity or acquired immunity. Why do we need a third line of defense? Don't overthink it. Why do we need? Yeah, just in case the other two fail. If something is resistant to inflammation. So can inflammation kill a virus? Not really. Because think about the innate, the inflammatory response, it's all based on cells. Viruses hijack cells. So we need something else to combat things that inflammation can't kill. The other big difference between the second and the third line of defense is that we get this long-term protection against future exposures. i.e., the third line of defense will produce this idea of memory. This will produce the idea of memory. You will remember who has attacked you. You will remember that you beat them before, and you will remember how to do it again. Okay. Second line of defense, doesn't matter what's attacking you. Treats everything the same way. Here, these are your specialists. Now we're going after a very, very specific target. That kind of helps there. So I don't know, like second line of defense, fire department. Third line of defense, your Navy SEALs. Okay. Now, out of your third line of defense, there are only two types of cells that you need to be aware of. B cells. B cells are also known as humoral B cells. I refer to it as B cells more often than not. Humoral refers to the humors or your bone marrow. That's how they get the name. But B cells, there's two types. Two types. You have B plasma and B memory. Okay, and we'll go over the different types of cells, what they do, etc. But this is just a list right now. And then you have your T cells. T cells, there are 4 types. Let me just list it over here. You have T helper, T cytotoxic, T regulator or suppressor. I'm going to say regulator. And T memory. Okay. So with your innate immunity, you had your granulocytes, your phagocytes, your dendritic cells. Third line of defense, just B and T cells. Now, if you notice, both of them share one thing. Both of them create what kind of cell in common? Both produce memory cells. This is what I was talking about with this way of remembering what has attacked you. There's a physical written set of instructions there. Okay. So before we get too crazy with it, just clarifying a little bit. I kept kind of using the term pathogen. Pathogen refers to anything causing disease. That means it could be fungus, could be bacteria, could be a virus. Pathogen is just a blanket term, an umbrella. On top of everything, you have antigens. These are specific kind of fingerprints that are unique to said pathogen. Staph has a certain set of antigens, flu, etc. Antibodies, these are things that you make to identify these antigens. Okay, so just clarifying the terms pathogen, antigen, and we will talk about antibodies. Okay, everything has a unique set of fingerprints. You actually have your own unique set of fingerprints on your cells as well. So viruses, you don't need to memorize any of this here, but viruses, they're kind of hard to kill. Thanks, COVID. Why? Here's your bacteria. Here's the red blood cell. What do you guys notice about most viruses? Oh, they are tiny. They are tiny. And do they just roam around on the outside? No. They go into your cell. They wear your face, wear your clothes, sleep where you sleep. I don't know. Eat what you eat. They're committing identity theft. How do you find something that is attacking you that looks like you? That's what makes viruses so tricky to kill. Okay? Because they're running around with your face. Okay? So when it comes to the third line of defense, there are different types of immunity. How it kind of works is you have active versus passive and natural versus artificial. Okay? I'll show you guys how we use these here, but just a little definition work. With active immunity, you actually get exposed to the real deal. So take, for example, let's talk about the flu. You get exposed to the flu. The idea here is that you basically learn how to produce antibodies, i.e. you learn new memory. Okay, versus passive, preformed antibody cells are administered, i.e. you receive antibodies from someone else, i.e. you receive someone else's memory. Okay. So a little bit of an analogy to help you guys out with this. Pathophys, this class, there's two ways to pass this class. A, you're active in your learning. You actively try to learn the information. When you actively learn about the information, you form a memory. You take the exam, you pass. Or somebody gives you the answer key. You passively receive the answer key to all of the exams. Good luck. None of them are in yet. But you guys see what I'm saying? Both would get you to pass, yes? Now, which one provides you a better investment for being a nurse? So which one do you think lasts longer? Okay. Active will last longer. Okay. And we'll get into more examples there, I promise.
Is passive like breast milk?
We'll get into more examples about that. But you guys see with active, you're actively trying to learn. Here, you're getting the answers. Okay. Natural, you're just exposed to it. Anytime you see artificial, I just want you to think injection. Anytime you see artificial, just think injection. Okay. So how this kind of works is you combine these different terms. Natural active versus natural passive, so on and so forth. So there are 4 different types of immunities. Okay, so we're going to break it down. Natural active. So let's start with natural. What does that mean? Yep, you're exposed to it. Okay, so I'm going to just say biologically exposed. And active. Yeah, you learn about it. So this is, you're biologically exposed. You learn how to make antibodies. Okay, so an example. Let's just say exposure to, let's say chickenpox. Okay. Kid in your class gets chickenpox. They start touching all your crap, guess what you get to look forward to? You get exposed to this virus because they licked your pencil, whatever. You learn how, you have to learn about this virus, then you learn how to fight this virus. Then you're protected for the rest of your life. You see how that's different from the second line of defense. If I get cut, doesn't matter if it's MRSA over and over again. I never learned how to deal with MRSA specifically. I treat everything the same way. Okay. Natural passive. So it's still biologically exposed. Exposed, but it's passive. That means I'm receiving somebody's antibodies. Receiving antibodies. I'm receiving somebody else's memory. So again, I'm going to say natural passive here would be like breastfeeding. Okay, let's think about this. Chickenpox. Most of you guys probably got vaccinated for chickenpox. I think that's a new thing. Older folks like myself, we had fun with it. Now, when does chickenpox typically show up in life?
Early elementary.
Early, like elementary age, maybe like 5, 10 years old-ish. Why not as a newborn? So when I give birth to a baby, just use your imagination. Okay? When I give birth to my baby, I'm going to start breastfeeding my baby. I have got the chickenpox. I have the antibodies. I take my answers and breastfeed them to my child. This is why the child doesn't get chickenpox during infancy. Now, according to WHO, we stop breastfeeding at 2 years old. Baby's removed from the teat. Baby's on its own. How long are those answers going to last? Not long enough, because guess what? 2, 3, 5 years later, chickenpox happens. So you guys see what I'm talking about is that's the big difference between passive and active. Here you remember, you learned about it. Here you just got the answers. Okay, so breastfeeding is an example here. Artificial active. So anytime you see artificial, you should think injection. So i.e., this is a vaccine. Okay, because what we're doing is we're injecting a deactivated virus. Now, this is one of the few times where I get a little spicy. Okay. Vaccines. Different vaccines work differently. If you are an anti-vaxxer, this is probably not the field for you. Okay. I kind of take a strong stance on this because measles is back. No kid should fucking have to deal with measles. Why is polio fucking coming back? Yeah. And this is America. Believe it or not, you want to believe, that's fine. But don't affect others. Right? So my big beef is if you're an anti-vaxxer or you're a flat earther, do not tell me. Do not tell me. Because I would lose my shit. So one way, this is just one way, how a vaccine typically works. You guys are familiar with the flu, how it has H and N to it, right? I don't remember the exact numbers. I believe H goes 1 through, you don't need to write this down. H1 goes 1 through 19, N goes 1 through 21. So you've heard of H1N1. H and N are the different antigens. We've discovered 19, I think, different H's, 21 different N's. And the flu can be any combination, H2N7, H7N1, okay? How a vaccine works is we find the virus and it has its antigens, that fingerprint. Okay. Normally inside of the vaccine, there's RNA in there. That's how it replicates. What we basically do is we hollow it out. We have a shallow corpse of a virus. That's what we get injected with. Now, does your body know that it's a corpse, that it's been deactivated?
No.
So you actually learn how to deal with this virus because you treat it like the real deal. Now, can you get the flu from the flu vaccine?
No,
Yes.
You can get flu-like symptoms. Why? Your body doesn't know if this is real or not. If you get flu-like symptoms from the vaccine, it's just your immune system being your immune system. Okay. Now, can you get the flu despite getting the flu vaccine?
yes.
Why?
Vaccines, features, depending
Mhm.
on.
What happens is each year we look at statistics around the world. We pull the 3 most probable strains that are going to go virulent. Now, stats, is it 100%?
No.
Sometimes we get it wrong, sometimes you still get the flu. This does not make you have 5G, all right? Like, this is not gonna make you magnetic. The government's not tracking you. And the other thing, like, no, this can cause things like Down syndrome. Okay? It's fine to have opinions, but do not push them on other people. The reason why I'm so strong about this is because science doesn't fucking care about feelings. Okay? You guys are going into this medical field here. Everyone has their own biases. That's fine. Do not tell me if you're an anti-vaxxer or a flat earther. Those are like my 2 fields. Love physics, love medicine. Don't. Okay. Now, question, and if you guys have questions about the vaccine, that's totally fine too. So I'm just saying flu vaccine here. If I got the flu vaccine last year, am I protected this year?
No.
Why not?
Because
It mutates, it could be different. If I get inoculated with 3 different strains and I never get exposed to them, what do you think my body's gonna do? Yeah, forget, why do we need it? Chicken pox. Why don't we ever forget chicken pox? There's kids running around everywhere. Right? So what I'm getting at is in order to maintain this memory, you have to keep getting exposed to it. So sometimes you can forget certain things. Some things you do remember for a lifetime. Okay. We good? All right. Artificial passive. So again, this is artificial, so you know it's an injection. When am I injecting them with if it's passive?
What?
Kind of, yeah. I'm injecting them with the answers. What's the answers an analogy for? The antigens. Injection of not actually antigens, but antibodies. Okay. So somebody was already exposed to the flu. They learned how to make antibodies. Let's use COVID as an example. Somebody got exposed to COVID. They learned how to make antibodies for that. We're going to harvest this person antibodies and shove them in that other person. Why? Why can't we just wait for the second person to develop their own antibodies? Why can't we just wait for them? Maybe they're immune compromised. Why else? Maybe age. Here's another example here. So let me say another example would be like anti-venom. I decide to go hiking and I get really friendly with a rattlesnake. Okay. Now I could sit there and I could wait and tell my immune system, like, you can do it, guys. You make those antibodies. But what's going to happen before I make those antibodies? What is the limiting factor? Time. This is when time is of the essence. Time is limited. Okay. So maybe a patient who's immunocompromised, they get the cold. They're going to die of the cold before they learn how to make antibodies. They're immunocompromised. You got to give them the answers now. So artificial passive, this is when they need the answers right now because they don't have the time to learn. Make sense? All right, so antigens, we talked about, these are like your fingerprints. Everybody has them. Everything has them. Okay, your own fingerprints is your self-antigen. So I'm going to say your own fingerprints. Tolerance. Now, take my word for this. Just the definition of tolerance is how well can you stand yourself? How well can you stand yourself? Well, some days it's rough. Last week was no rough. That's weird. Why would we need to stand ourselves? How do viruses work? They hijack cells, your own cells, and they replicate inside of them. They're walking around with your face. How closely do we need to look at our cells to see if there's a virus in play? How closely do we need to look? That's tolerance right there. Okay, so let's think about this. If you have the flu, you have a viral infection. Do you want a high tolerance or a low tolerance? So if you're highly tolerant, that means you're letting things pass, no problem. If you're virally infected with the virus, do you want to be checking your cells very closely? Yeah. So during an active infection, let me say viral infection, we want to lower tolerance. We do not want to be able to stand ourselves at all. Therefore, you right now, being healthy, not exposed to a virus, what's your tolerance at? It's pretty high. So I'm gonna say normal life, high tolerance. So tolerance is really talking about like how closely are we looking at ourselves. Allergens, I'm not gonna really get too crazy with. You don't even need to take notes on it. I'm not gonna ask you to drug this allergen. It's just something that triggers the immune system that is non-harmful. So think of spring, pollen from a sunflower. You inhale pollen, it's an allergen. What happens? Sneeze, what happens to your eyes? Your nose? Sunflower has now made you miserable. Can that sunflower kill you? Not really, but your body doesn't know that, and that's why it still elicits an immune response. Okay. All right, what are antibodies? Antibodies are also known as immunoglobulins. Heads up, I use both words interchangeably. Okay, these are made by your B plasma cells. Okay, so antibodies, these are specially made proteins to go after H1, N2, H3, whatever virus, whatever fingerprint, whatever antigen. Okay. So immunoglobulins, also known as antibodies, made by your B plasma cells. These are the immunoglobulins you need to worry about. For each immunoglobulin, you need to know like one or two things, nothing too crazy. Okay. IgG, this is known as the quote unquote killing antibody. This is the thing that's going to go around actually killing or deactivating most viruses. Okay. The reason why I say IgG, immunoglobulin G. It is by far the most abundant. Don't need to worry about the other two. IgM, this is the learning antibody. Okay. Yeah, it's the largest, but that's not important. This second point here, let me translate it below. This is the first antibody produced during primary response to an antigen. First antibody produced during primary response to an antigen. So what do I mean by this? Chickenpox, going back to chickenpox. The first time you were exposed to chickenpox, as you were breaking out in hives and itching all over the place, your body's making a bunch of IgM. What IgM does is it goes around and tries to figure out what is trying to attack you. It's trying to figure out that antigen, the antigen for the virus. Once we have the correct IgM, again, during the primary response or first response, once we have IgM, once we've learned about it, now I can make the killing. Okay, so IgM and then IgG. There's a slide coming up that highlights this. IgA. Be careful here. IgA is not for allergies. A lot of students switch those up. Okay, IgA is for secretions. What are some example secretions? Mucus. What else? Tears. Sweat. Saliva. What else? Yeah, kind of. I was thinking like breast milk. Huh. Mucus, tears, sweat, saliva. Kind of rings a bell. What kind of line of defense is that? This is why your first line of defense, your chemical barriers, has that antimicrobial properties. This is why your tears can prevent bacterial growth, because it has IgA. Okay. Now, IgE. This is for your allergies. Also, you see IgE with parasites. This is the way I remember this. IgE is for parasites. What other cell helps fight parasites? Eosinophils. They work together to fight parasites. Okay. Now, if you notice something, I skipped one. So a little bit about my lecturing style. Do you think I'm going to ask you a question on IgD? Not at all. So like one or two things about each antibody. Again, they come from your B plasma cells. Okay.
You say we don't.
Yeah, don't worry about IgD. Okay. Now, how do your antibodies actually kill viruses or etc.? They can directly kill a virus or they can indirectly kill a virus. So let's kind of think about this. If I am directly responsible for somebody's murder, what does that mean? I did it. So a direct antibody function, this is when the antibody kills the virus. However, if I am indirectly responsible for somebody's murder, what does that mean?
You're allowed to make it do it.
Yeah, like I paid the hitman or I got my friends together, right? So the indirect means the antibody calls on its friends. In this case, I'm going to say like other cells to kill the virus. So direct, antibodies going after it. Indirect, antibodies calling on its friends. Okay. So neutralization, this is very similar to what we talked about with the plasma proteins. This is where we're going to cover the pathogen. In this case, not with plasma proteins, but cover the pathogen with antibodies. Okay. Agglutination. So if anybody's a baker, gluten sticks together. Agglutination is going to make things stick together. Now, why would we want that? Little easier to locate. So if I went crazy and I started fire right here, hopefully you guys all leave through that door, right? What happens if I super glue everybody's hands together? Yeah, you're gonna get stuck, you're gonna have trouble moving. that puts you at risk for getting burned. If I agglutinate stuff, it's going to cause things to stick together. That's going to isolate those cells. Should not back. And that kind of plays a role with phagocytosis here. If you have a whole bunch of viruses just stuck in one place, that makes an easy target for your phagocytes to come by and eat them up. Okay. Precipitation, there's not really an easy analogy for this one. This is where we turn soluble things insoluble. Okay. The best way I can describe precipitation, you guys remember in chemistry class when something precipitates, you get some like sediment at the bottom of your beaker, right? Sometimes when an antibody lands on a virus, we can basically cause its RNA to solidify. Basically, it's like your GI tract turning to stone and then falling out of your butthole. That's precipitation. Not really going to test you on that one. Okay. All right, so indirect inflammation, this is when I'm going to recruit the second line of defense. Okay, phagocytosis, again, who are my phagocytes? Mm-hmm. It's just easier for me to just read it. Dendritic cells, macrophages, neutrophils. In your complement system, anybody remember about the complement system? What does that do? It sticks to things. It's what kind of system? It's like a tagging system, right? So why would I want to tag something even further? So take, for example, I lived in Boulder a lot. So you guys ever see Pearl Street? There's some great people watching there. Okay. If you're sitting at Pearl Street and doing yourself a nice mimosa with brunch, and you see somebody walk by with an ankle monitoring bracelet, what do you know? What are you doing outside? You look a little bit closer, and now you see this person's also handcuffed. And are they wearing orange? You see how this escalates that scenario. The more things you tag it, the more serious it becomes. Okay. Cool. So how does the third line of defense kind of work? How do we actually like learn this stuff? So your primary response is also known as your initial exposure. So i.e., this is the first exposure to, I'm going to say chickenpox as the example. Okay, when you first get exposed to chickenpox, do you know that you got exposed? No, usually you find out about a week later, give or take a few days, right? There's this lag phase because that virus is just replicating. Okay, how long does the chickenpox typically last, those hives? 7 to 10 days. It can vary depending on whatever virus, but typically you don't need to memorize this, but like about a week. Why does it take a week? It takes a week for IgM to learn about that virus. It takes about a week for IgM to figure out that specific antigen. Okay, once I finally figured out what's trying to attack me, what can I make to kill it? IgG to kill it. So the first time you get exposed to chickenpox, life sucks for about a week because you're learning how to fight it. IgM's the learning one. Once you've learned how to fight it, now you can make the answer. You can make IgG. Okay. So what happens when you get exposed again? Your response is much more rapid. So let me say second exposure to chickenpox. Your response is much more rapid. Why? Why isn't, when you get exposed to chickenpox again, it's over and done? Your body has learned, your body has produced that memory. We already have memory. So what antibody can I just make right out of the gate? IgG is produced in considerably greater numbers. Okay. Hopefully you guys are seeing it's like a two-step process. Okay, IgA, again, this one's the one that's present in your secretions, i.e. your first line of defense. Cool. So how do we make these cells, these Navy SEALs? Two steps. How do we learn how to actually build, or how do we actually build this third line of defense? Two steps. Step one is clonal diversity. Diversity, different. The idea here is to make as many different, big Q term here, immunocompetent cells as possible. Okay, immunocompetent. I promise to explain immunocompetent. But clonal diversity, trying to make as many different immunocompetent cells as possible. Okay. Step two, clonal selection. This is when you choose an immunocompetent cell to mature. So when you choose an immunocompetent cell to mature. Okay, so a bit of an analogy. Clonal diversity, this is you out of high school. You're technically recognized as an adult, you can do anything. You can go to university, go to college, trade school, work, whatever you want. You can do anything you want. But are you an adult yet? Barely, right? I mean, like, how much experience you got at 18? Not much, right? Clonal selection, that's when you have fully committed yourself to a career path. You're going to be an expert, a specialist in one specific area. These cells are ready to work, they just haven't worked yet. These cells, they're working. They're specialized. Okay? So that's kind of the analogy there. So nice little picture here. Step one, clonal diversity. So the whole idea, again, is to make as many different immunocompetent cells as possible. Okay, now how do we make immunocompetent cells? They come from your bone marrow. What I mean by immunocompetent, let me just define it here. Immunocompetent. They are ready to detect an antigen, but just haven't yet. You're ready to work, but you just haven't started working yet. Okay. Now, why do we need so many different immunocompetent T and B cells? Your T and B cells can only detect one antigen. You remember how I was talking about H and N? H was like 1 through 21, and then N was like 1 through 19. You need an immunocompetent T cell to detect H1. You need another one to detect H2, H3, 4. How many viruses are out there?
Too many.
A lot. So you need to make a bunch of them. Millions of them. Okay. Now, once You have all of these immunocompetent T B cells ready to detect something. They sit and wait. They sit and wait until something comes by, an APC. Notice this APC appears to be carrying antigens. It appears to be carrying a face or body parts. It's going to hold this torn off face to the crowd of immunocompetent T cells and B cells and say, who recognizes this face? And only one of you will raise your hand and say, I do. That's why we're tearing off faces. That's why we're wearing dead parts as jewelry, because we're going to bring them all the way back here and ask who recognizes this. And only one T cell can say, I do. And only one B cell can say, I do. Now that we've recognized something, now we can go on to clonal selection. So take, for example, this is you. When you're born, you're waiting. A dendritic cell comes by with the chickenpox antigens. Now, one B cell, one T cell says, I recognize it. You mature them into your final adult cells. This is when you choose which ones to mature, the ones that have actually shown to recognize something. Okay. So, yeah, that's just overview. We'll talk about it here. Okay. So all of your B cells start as B immunocompetent. Okay. All of your B cells start as immunocompetent cells. Now they can mature, but what do they need to be exposed to mature? The antigen. So when I expose it to antigen, it can become one of two things. It can become a B plasma cell. Anybody remember what does the B plasma cell do? That's the one that makes your antibodies. That makes your IgG, IgA, IgM, IgE. Okay. The other one it can become is your B memory. Okay, so let me say B plasma makes antibodies or immunoglobulins. What do you think your B memory does? What it does is it takes that antigen it was exposed to and weaves it into its own DNA. When I was talking about inheriting memory, it's a physical memory. Freaking cool. So your B memory, its job is just to remember. Okay. Now your T cells, there's a bunch more. So all of your T cells start as T immunocompetent. And you expose your T cell to an antigen. There's not really an easy way to draw that just because there's not enough space. So I'm just going to list out what happens when you expose it to an antigen. Maybe I'll do it like this. Plus antigen equals, you can get a T helper cell. Anybody remember from the crash course what the T helper cell was akin to? They're the top dog. These are the generals, was the reference. So these are the generals of the immune system. Their job is to coordinate the entire immune system. Okay, they're the ones that say, hey, we need more neutrophils, we need more macrophages. Tell the eosinophils to turn it down. They coordinate everything. Okay. T regulator or suppressor. Actually, I should just write these out, sorry. Regulator or suppressor. I call them T regulators more often than not. These control tolerance. Again, why would I need to lower tolerance? Yeah, that's viruses, right? Maybe I need to lower my tolerance because I have a virus going on. Who told my T regulator cell to lower my tolerance? Guessing what I'm saying, the T helper cell has fingers in everything. Okay. Next up, T cytotoxic. Cyto, cell, toxic, poisonous. What this does, it's going to kill virus or cancer infected cells. So once we have identified a cell that is dysfunctional, that has a virus or even cancer, your T cell, toxic cell will walk up and basically pop a hole. What happens when you pop a bubble? Yeah, when you poke a water balloon, sorry. All of the insides become outsides, right? That's what your T cytotoxic does. Now let's think about this. Where do viruses live? Inside of your own cells. Where does cancer live? What is the only kind of cell that your T cytotoxic can kill? I think you're thinking about it too hard. Can only kill self cells. They can only kill self cells infected with a virus or cancer. Because virus lives on inside of you. Cancer lives on inside of you. Okay? So your T cytotoxic cells, are they good for attacking new bacteria? Only your own cells.
So your own cells that are infected.
With a virus or cancer. Yeah. Last one, T memory. 3 guesses. What does T memory do? Yep. Okay. So these are the different cells. This is what they do. There's going to be slides on it. Let it go quicker. All right, so clonal diversity. Again, the whole point here. Something's vibrating like crazy.
I'm sorry, that's myself.
Oh, you're good. You're good.
It's like on the border, so it's-
That makes sense. I was like, it sounds like it's resonating. That's cool. All right, clonal diversity. The whole point here is to produce immunocompetent T and B cells. Why do we need so many different B and T cells? They can only recognize one antigen. Okay, so step 1, make a bunch of B and T immunocompetent cells. When do you need to do this? Well, while you're in the womb, during fetal development. Why? Because as soon as baby pops out, baby's technically at risk for being exposed to any virus. So, i.e., you better be ready to fight viruses by the time you come out. Okay. B cell development. The reason why B cells get their name as B cells, they are going to start and mature at the bone marrow. So your B cells are made in your bone marrow. Where they become a B memory cell or a B plasma cell, also your bone marrow. That's why they're called B cells. Okay. T cells, they're going to start at the bone marrow. All of your blood cells start from your bone marrow, but they're going to mature at the thymus. What's a thymus? It's not your thyroid. Not gland in the brain. It's kind of weird. You guys, it's a weird organ. It's actually right underneath your rib cage, in between your ribs and your heart. Here's the weird thing though, you don't have a thymus anymore. That's why you've never heard of it.
Yeah.
So kids, they're born with a thymus, the sac. This is where the T cells go to mature. As soon as the kid starts undergoing puberty, by the end of puberty, that thymus shrinks, and is gone. So puberty is when you start shrinking. So you as adults have this little noodly appendage in front of your heart. Does that mean you can no longer mature your T cells? You still can. In adult, I guess I didn't have there. In adults, you mature them in your lymph nodes. Okay. So that's just kind of a fun fact. For now, what you need to worry about is just thymus for maturation. Just as adults, you rely on your lymph nodes. Okay. All right, so clonal diversity, you're trying to make a bunch. Clonal selection, this is when we choose which immunocompetent cells we're going to mature. Clonal selection is initiated when T and B cells interact with an antigen. So step one, make cells. How do we go to step two? You expose them to that face with those body parts. Okay. Now, who is carrying that face? APCs, i.e. antigen presenting cells. Think back earlier in lecture, who's walking around carrying a face? Dendritic cells. So dendritic cells are an APC. Who else is walking around with some body parts? Macrophages. Now, if you notice your dendritic cells and your macrophages, they're both phagocytes. So could a neutrophil technically be an APC? As soon as a neutrophil takes a bite out of something, it dies. So that's why neutrophils are not an APC. They can't carry that body part back. Okay. Cool. And thankfully, we've already talked about these and we've already written them out, so it goes a lot faster. When your immunocompetent B cell encounters an antigen, it can become a B plasma cell. What does a B plasma cell do? Creates the antibodies, the immunoglobulins. B memory cell, what does that do? Remembers. T cells, right? T cytotoxic, T helper, T reg, T memory. I'm just underlining them here, but we already wrote them before, so not a huge emphasis on the slide. Okay. Okay. Now talking about your T cells, what do you guys remember about the T helper cells? They direct everything with which bodily system? The immune system, right? Now, as a nurse, when you run labs, you're not going to find a lab that says T helper cell count. Instead, you're going to see CD4, CD8 counts. So CD4, CD8, these are going to be receptors on your T cells. Certain receptors for certain T cells. Okay. So CD4 is a receptor found on your T helper cells. So what I'm saying is T helper cells are also known as CD4 cells. This is going to be particularly important for med surg when you start messing around with people's labs. Heads up can go both ways. A T helper or a CD4. CD8 is referring to your T cytotoxic cells. Okay, again, it's just named because those are the specific receptors. CD4 is the helper cytotoxic, CD8. Now, why is this important? On all of your cells, you have what's called an MHC, or major histocompatibility complex. MHC1 and MHC2. So let me just kind of write this down and then I'll explain it, okay? CD4 binds to MHC2. CD4 binds to MHC2. CD8 binds to MHC1. Okay, why on earth are we talking about? MHC, this is your own special fingerprint. So all of your own cells are covered by MHCs, okay? MHC1 is found on your immune cells. MHC2 is found on all of your somatic cells, your other cells. So your T helper cells need to communicate with who? Your immune cells. So CD4, therefore, has to bind to. Oh, I switched that. Damn it. Sorry. Swap them. I swapped them. I'm sorry. MHC2 is on the immune cells. MHC1 is your somatic cells. My bad. Sorry. So your CD4 needs to talk to your immune cells. Therefore, 4 binds to 2. If you don't want to remember any of that, that's fine. I got you. Magic rule of 8s. What the hell binds to what? 4 times 2 equals 8 times 1 equals Yahtzee. You just need to know what binds to what. Sorry. Okay. So the why behind it, if you're curious, your T helper cells need to communicate to your immune cells to turn things up, turn things down. Your T cell, toxic cell, these are the ones going after viruses, after cancer cells living in your somatic cells. That's the why. Okay. So if you need a picture, I got you. CD8. What was another name for your CD8 cells? T cytotoxic. This is your T cytotoxic cell. What happens is we go to one of your somatic cells, so it's a somatic cell down here. And you have this MHC protein. On top of this protein is this peptide. I want you to think of this as MHC is the flagpole. The peptide is the flag color. Okay. Now, let's say your favorite color is purple. You're going to fly a purple flag right here, signaling that everything is okay. That takes energy, that takes resources, but you're still okay. So what happens if a T cell, cytotoxic cell comes by and there's no flag? What does that tell you about that cell? Something is wrong. Maybe a virus has stolen all of my flag making materials. Maybe I got cancer in there. That's how your T cytotoxic cell identifies a virus or a cancer infected cell. Okay. CD4 is your T helper. It's just talking to your immune cells. Okay. Now the third one here, natural killer cells, have the most badass name, but we will not talk about them. They're they do their own thing. Okay. So T helper cells, what do they do? T helpers, they coordinate the entire immune system. What's another name for your T helper cells? CD4 cells. Cytotoxic T cells, also known as CD8. So T, actually, we just also known as your CD8 cells. They destroy cancer cells or cells infected with a virus. Okay, what ends up happening is they use porphyrin, for lack of better terms, it's like a prison shank. Because what's going to happen is it's going to walk up and pop a hole in the cell membrane. So now the cell is deflating, all of the insides have become outsides. Okay. All right. So I was going to use this slide to kind of tie everything together. I'm going to just pull up a blank slide here, so we're going to kind of wrap it all up together in one shot here. So, you guys cool if we take like a 5-minute break really quick? I gotta figure out what's going on with my washing machine. It got flooded this morning. And it's been sitting in a tub. My dad just texted me, so it's fine. So let's take a 5-minute break. I would say come back with a full sheet of paper. We're going to recap this entire thing. Okay.
So it makes sense. So. Okay.
Sorry, I didn't know.
So it's not. Like.
All right. Good, good. So we're gonna just recap this whole thing. What I would recommend for this one, don't try to fiercely write stuff down. A, because this is being recorded, B, you can take a photo of it, right? What I would say is use this just as a memory recap. Try to like talk about the big picture stuff because within the biggest challenge for students is they get lost in the details. Okay, so use this as an overview and then you're gonna have plenty of time to copy stuff down. Okay. All right, so we had that first line of defense. It was composed of what? Physical and chemical barriers. Then we had the second line of defense. Now, when we did this before, I kind of fleshed it out a little bit more. I'm gonna kind of leave this more like blanks because I want you guys to go home tonight and try to actually write this whole thing out. Okay. How many names were there for the second line of defense? 3 names. Okay. And the thing that kicked us all off was mast cells. Okay, mast cells. 2 functions of your mast cells. What were they? Degranulate and synthesize. Okay. And what kind of things did we degranulate? Histamine and chemotoxic factors. How many effects of histamine were there? 2. Vasodilation and increased capillary permeability. So what I'm just doing here is saying 2 effects. When you guys go home tonight, you're gonna actually fill those in, like actually get a proper piece of paper to do this, okay? Synthesize, what are we synthesizing? Histamine-like prostaglandins and thromboxanes, yeah. Okay, so again, what do we use chemotaxic factors for? What do we use prostaglandins for? What do we use thromboxanes for? When you guys are writing this out, you'll fill that in. Okay. Your chemotaxic factors are going to bring along some friends. That's your granulocytes, your phagocytes, your diapetic cells. Okay. Now, alongside your mast cells, we have a chemical response. What is that chemical inflammatory response? No, no. It's in your blood plasma. Plasma protein system. How many plasma protein systems were there? You had your complements, coagulation, radiation. And again, when you guys are at home, write out complement system, that's your timing system, coagulations for clotting, bradykinetics for pain. Right, so just flush it out a little bit more. But this way you kind of know what you're looking for. Now we finally come down to the new section here, which is there you go, third line of defense. It's known as the adaptive / acquired immunity. Okay. Now, what was the first step in building this line of defense? Something diversity. Step 1, clonal diversity. And what does clonal diversity do? What are we doing? We're producing immunocompetent B and T cells. Okay, what's step 2? Clonal selection. This is when we're going to mature B and T cells. Okay. Sorry, let me just kind of fill this in really quick. Then question is how? How do we go from step 1 to step 2? Has to be exposed to an antigen. Who's carrying the antigen? So I'm going to write antigen here. And you're right, an APC is bringing it. Who are my APCs? So the reason why I kind of drew those in there to show you, hey, look, yes, we have 3 different lines of defense, but they are not exclusive from one another. There's interaction between, in this case, the second and the third line of defense. Where the second line of defense is helping the third line of defense. Okay. Now, when we mature our B and T cells, how many T cells do we get? 4. We have T helper, T cyto, T reg, and T memory. B cells, how many B cells you get? B plasma, B memory. Now, B plasma cells, what do they do? They make them antibodies. Now, here's the hard question. What were the antibodies you were responsible for? Those are the T helper cells and T cytotoxic cells.
We got IgN, A,
Oh, well, that's convenient. Smells game. That's the way I would do it. Okay. Now, IgG, that's the killing one. IgM is the memory one. IgE, parasites, allergies. IgA was present in your secretions, which we linked back to which line of defense?
and first.
Okay. So what I'm getting at is, again, look at this. The third line of defense is helping the first line of defense. There's interaction between these 3. It's not just 3 different people doing 3 different things. They all help each other out. Okay. Yeah. I'm going to scoot down a little bit here. I would say other things to kind of mention. I had a second sheet. Local versus systemic infection. Okay, with local, what do you expect? Sharp. What about systemic? I'll leave the keyword up for you guys to look up. And the other one is the other different types of adaptive immunity. There were 4. It's that natural, active, natural passive, artificial, active, artificial passive. Okay. So I'm going to leave this here. Feel free to take a picture. Feel free to draw it down. You guys still got 15 minutes. I'll be chilling if you have questions. Okay. Good job, guys. Once a week if you want.
This is 50% of our, this one. Or about that. More right.
I would say it's maybe like this lecture today makes up about 35 to 40% in combination with some of the material tomorrow. Then we have our 50.
Okay.
Yeah, metal.
Yes.
Okay.
So I looked and I saw these here, it's like listed a bunch of chapters. What chapters are we at?
I don't know. I actually don't know the chapters of the book.
Okay.
So I would say just if you're using the textbook, yeah, if you're using the textbook, like in the lectures, it should tell you.
So we have just one more lecture.
I deleted it.
So what we have is tomorrow, and then it's like all of that is on
Kind of, only half of tomorrow will be on the exam.
the exam.
But when we meet tomorrow and I give you guys the exam briefing, I will explicitly tell you what subjects you need to worry about for the exam.
Okay.
So we could just sum it up as like page 1 through 4.
Yeah, basically, yeah, you can do that, 1 through
3.5.
3.5. Usually it's 1 through 3. There's not usually a spillover, but with the beginning of the quarter and immunology. So that much. Oh, I should not have done that.